Hello and welcome back to the channel. You are watching T-Physio Guy. In this video, we will learn about TBI or brain injuries that's called traumatic brain injuries. We will learn about the definition, the causes, the prevalence, the mechanism of action of this disease or injury, the rehabilitation framework, the evaluation scales, and the physiotherapy management. If you are a clinician, if you are an intern and observer of physical therapy, so this video can really help you while doing your treatments. So let's start with what is the proper definition of TBI. TBI is called the alteration in brain function due to any external factor or force. TBI can be one of the most challenging injuries to deal with for a clinician as well as a paramedical staff, whether it is a healthcare professional or you are dealing with TBI as an attendant. So knowing some information about TBI can be very helpful in your clinical practice. So coming back to TBI, TBI is basically very challenging and situation for both the patient as well as the clinician. It can be very challenging and lethargic for both patient, physical therapist or clinician to treat with. But if treated well and at time, so the prognosis is fruitful. Now, TBI, what happens in TBI, there is two types of injuries basically. One is open head injury and the other is the closed head injury. In the open head injury, what happens is the penetrating object penetrates the skull and comes in contact with the brain. And in the closed head injury, what happens is the external force comes in contact or external object comes in contact with the skull but doesn't penetrate into the brain tissue. Now coming to the types of brain injuries, there are two types of brain injuries. One is traumatic brain injuries and the other is non-traumatic brain injuries. If we talk about traumatic brain injuries, these are brain injuries that are caused due to fall, trauma, RTA, motor vehicle accidents, assaults, and suicidal attempts. While the non-traumatic cause can be a brain hemorrhage, an infection to the brain that might lead to brain injury that can be injurious to brain. So these are two categories of brain injuries. Now coming to the prevalence, if we talk about in America, about 1.7 million people every year suffers from TBI. And if we talk about the younger adults, the hospitalization ratio is very common and very high in younger adults and pediatric population. But if we talk about the mortality rate, so the mortality rate is very high in elderly patients. So this is the prevalence. Then coming to the sequelae of the mechanism of injury, or you can say pathophysiology of the injury. What happens is there are two types of injuries. One is the primary injury, one is the secondary injury, and the third is the blast injury. I will discuss blast injuries in mid after discussing the primary injury. Blast injuries mostly occurs in, remember, in law enforcing agencies or soldiers or army personnels. So first we will discuss the primary injury. In the primary injury, what happens is when there is a hit, the external object or external force or object penetrates the skull and comes in contact with the brain. When there is a contact with the brain tissue, so there is hemorrhage, hematoma formation inside the brain, leading to necrosis, and due to severe acceleration and deceleration of the brain tissue, what happens is there is diffuse axonal injury. When there is diffuse axonal injury, that might lead to the primary injury in TBI patients. So this was the mechanism of the primary injury. Now, before coming to the secondary injury, I will discuss about the blast injury. Blast injuries, as I said, happens in army personnel. So what happens is when there is an IED blast or an explosion, so the explosive contents comes out of that explosion. So when there is an explosion, there is a shockwave propagation from the external environment to the body. Once it goes into the body, it increases the intra-abdominal, intrathoracic pressure and increases the ICP, intracranial pressure, leading to the transfer of kinetic energy from external environment to the internal environment, leading to increase in ICP levels and CSF levels, abnormal CSF levels. So one cause is the shockwave propagation. Second cause is when the patient, when the shrapnels of that explosive comes in contact with the body or the brain. Then the third thing, the last thing that happens in blast injury is when the patient, after getting hit by the shrapnels, fell down to the ground and his head bumps with the hard surface. So this is the three main factors in the blast injury. Now coming to the secondary injury. What happens in secondary injury? After the primary injury, there are various chemical reactions and cellular events that is going on. So the first event that happens is glutamate neurotoxicity. There is excessive release of excitatory neurotransmitter that causes leakage of fluid ions, and once there is a fluid leakage, so there is a chances of brain herniation, and this causes increase in CSF and ICP levels. So this is the main primary mechanism or pathophysiology of traumatic brain injuries. Now I will discuss the neurological impairments in the traumatic brain injuries. First, let's talk about the neurological impairments or neuromuscular impairments. In neuromuscular impairment, there might be abnormal tone in upper limb or lower limb. There will be any postural imbalance. There will be an effect on the postural stability of the patient. There might be some positive syndromes due to the damage to the brain. So this is somewhat neuromuscular changes that happens in TBI patients. Now coming to the cognitive impairments. Now what is cognition? Cognition is basically gathering the information, knowing it and implementing it. That is called cognition. Now cognition is controlled from the frontal part of the brain. So it is seen that mostly there are cognitive impairment. The onset of cognitive impairment is very high in TBI patients. Now there is always a decrease in executive functioning, executive memory of the patient. Executive memory is self-generating questions, solving problems, and solving simple questions, solving simple, you can say, simple problems are all in the executive functioning of the brain, executive memory of the brain. So TBI patients are mostly involved in this neurological cognitive deficit after TBI. Now coming to the alertness during TBI patient. There are 3 or 4 types of levels in a TBI patient. First is coma, second is vegetative state, one is minimal alert state, stupor and obtunded. Now I will talk about coma first. In coma, the difference is that there is no sleep wake cycle of the patient. Mostly the eyes are closed, and in coma, the patient might be in complete ventilatory support, and patient will have no uh, observation or alertness to environment and environment around him. So this is coma. Coma is said to be temporary state. It can patient can remain in coma for 2 days, for a year, for 3 months, and so on. Coming to vegetative state. Now, what is the difference between them? In vegetative state, what happens is there is some disassociation between a wakefulness and alertness and opening of the eye. And there is sleep wake cycle. Third is there is some development of reflexive crying and smiling in the patient. It is seen in vegetative state. And there is one factor that the patient might be out of ventilatory support. In minimal alert state, the patient is alert but inconsistently. The patient responds to stimuli. The patient has some awareness around the environment. Now coming to stupor and obtunded. Stupor is a condition in which you give a very painful stimuli to the patient, and the patient is alert but for a shorter period of time. Obtunded is little different from it. In the upcoming videos we will talk about this, because these two terms are little difficult to distinguish. So we will talk this in later. Now coming to the communication impairment. What happens in communication impairment? The patient always speak in tangential words are there. Words are disorganized. The thing he is speaking is non-meaningful, and there is problem in generating the word. There is problem in generating the word formation. So this is kind of communication impairments that occurs in TBI patient. Now there is a neuro behavioral impairment. There's first thing is short temperness. The aggression is very high. There is a apathy, agitation, and irritability in doing normal things. There's a term called dysautonomia. Dysautonomia is basically a sudden increase in blood pressure, respiratory rate of the patient. It is due to the. Okay, now we will discuss about the GCS scale, that is Glasgow Coma Scale. If we talk about eye opening, if you go to a ward or if you go to the room and the patient eyes are open and he is looking all around the environment, then you will grade him as spontaneous 4. But if his eyes are closed and name 2 or 3 times, then he opens his eyes, so it will be in 3, grade 3. If his eyes are not open and after calling his name still the eyes are closed, you will go for a painful stimuli. Painful stimuli can be on 2 main parts that are more common: sternal part and the paraorbital notch. These are two painful points that causes the eye opening of the patient. If there is again no eye opening to even the painful stimuli, so then it means there is no response by the patient, and we will grade as 1 out of 4. Coming to the verbal commands, if you go to the room of the patient and you ask his name, you ask the time, you ask the place where he is in, and the person next to him. If he confidently and successfully tells these 3 things, that means it is in grade 5. If he is confused in any of these 3 things, that means he is confused. Like he tells time but it is inappropriate, tells the person standing near to him in the place he is in. These 2 things he tells right, but one thing he tells wrong. This means he is confused. Then coming to the 3rd grade, in which the patient will speak words, will tell words that has no meaning, that is inappropriate. That will be grade 3. When you ask the question, where are you, who is with you, and what is the time? If he speaks or tells inappropriate words, so it means that he is in grade 3. There is no meaning of what he is talking about. Second is the incomprehensible sound, in which he will be trying to speak, but the words he is speaking cannot be understood by the clinician or by the attendant. So it will be grade 2. And in 1, there will be no response. Coming to motor, in motor, if he obeys commands, you can give simple commands like move your right hand to your left ear, or move your left hand to your right ear. So it will be following that. So it will come in grade 6. In grade 5, what will happen is when you give a localized painful stimuli, he will move towards it. He will move his hand towards it. That is called localized site of pain. So it will be grade 5. If the patient flexes his limb to withdraw from pain, it will be in grade 4. If the patient has abnormal flexion in the limb, that is grade 3. If the patient has abnormal extension, that is, these 2 terms are called decorticate, decerebrate जो है posture. So he will be in grade 2. In 1, there will be no response of the patient. Okay, now coming to the crash reporting. Crash reporting is done after the acute management, in which the doctors calculate the 6 months outcome of after the TBI attack, the disability index and the mortality rate within 14 days. Crash is called the corticosteroid randomization after significant head injury. Now it is a tool in which you put the patient's age, comorbidities, height, means the BMI, weight, the CT scan findings, the glucose level, everything you put in this, and then you submit it. And then the tool determines the 14 days mortality rate of the patient and the disability rate of the patient. How much disabled will be the patient after this TBI attack. So it is a very, very great tool that could be used to determine the prognosis of a patient suffering from TBI. Okay, now let's talk about a scale for cognition, that is Ranchos Los Amigos scale. Basically, it has 8 levels. I will start from level 2. The level 2 is called generalized response. There is a reflex response to painful stimuli by the patient. Coming to level 3, that is called the localized response. In this level, what happens is patient blinks to strong light, turn towards and away from the stimuli. The level 4 is called confused agitated. The patient is alert, performs motor activities, but the behavior is non-purposeful. Coming to level 5, that is confused, non-agitated. Gross attention to the environment is present, but inappropriate verbalization. Then coming to level 6, that is called the confused appropriate. Now in this level, what happens is inconsistent orientation to time, place, but consistently follows simple commands. Coming to level 7, that is the automatic appropriate. Skill noticeably deteriorates within time. Then coming to level 8, that is the last level. It is called purposeful appropriate, in which mostly 50% of the patient does his ADLs, activity of daily living, and can complete simple tasks. So this was the scale for the cognitive level of the patient. Now coming to the continuum of rehabilitation care. Before that, we can discuss about the acute management of TBI. In the acute management, what happens is you have to manage the respiratory and cardiovascular system of the patient. The oxygen should be maintained above 90%, and the systolic blood pressure should be less than 90 mmHg. The neck should be stabilized with the collar. Head should be elevated to 30 degrees, and surgery if there is a skull fracture or hemorrhage. Vascular drainage to maintain ICP in subdural boards or fiber optic catheters. Now coming to the continuum of rehabilitation care. In this rehabilitation framework, the first most important person is the family, because the family knows, you can get a lot of information from the family, whether the patient was the bread earner of the family, whether he was the youngest, what was the mood, what was the cause of this TBI injury, why it caused a TBI injury, if it was a suicidal attempt or a fall attempt, what kind of profession did the patient belong to. All this history can be taken from the family. So the family member is very important in the rehabilitation care. The second most important member in this rehabilitation team is the rehab specialist. Rehab specialists are MBBS doctor, medical doctors that have done specialization in rehabilitation medicine, physical medicine. So these rehabilitation expert maintains the medical stability of the patient, looks for the medical stability of the patient and the complications of TBI, and the drug management of the patient is done by the rehab specialist. Then coming to the rehab nurse, third most important uh, member. Why? Because post TBI there can be complications if there is a ventricular drainage given to the vascular drainage, sorry, given to the patient, and and there is a after fracture there can be some complications that can develop. So the rehab nurse is fully capable of dealing with these complications, majority of these complications. Then come physiotherapist. Physiotherapist is a mobility expert, joint and mobility expert. So after TBI, to avoid bad complications, this is the work of physiotherapist that he do in acute setting or in ICUs or during wards. So physiotherapists basically work on early range of motion and prevention of bad complications. Then there is a neuropsychologist, and there are some certain behavioral issues that occurs after TBI. So a neuropsychologist is fully expert in dealing with that. Then there's OT, that is occupational therapist. Occupational therapist is someone who will work on ADLs and fine motor skills of the patient after TBI. It is very effective in mild cases of TBI to regain activity of daily living like eating, bathing, combing, self-dressing. All these stuff are done by the occupational therapist to retrain the patient after a physical disability. It is the work of the occupational therapist. Now coming to the speech language pathologist. Speech language pathologist basically works on you can say speech disorders like tangential speech, difficulty pronouncing a word, difficulty initiating a word. That is done by the speech language pathologist. Then the last one is the team coordinator or case manager. It can be any paramedical staff or someone who is good at managing patient and uh, the attendance of the patient. So this is the case manager who will determine all the cost, all the sessions, and all the treatments that are required by the patient. Coming to early rehabilitation and physiotherapy protocol, the goals are very simple: to avoid bad complication and promote bed mobility, improve power rooms and reduce contractures in an early case of TBI. Now, what can be the you can say treatments for early mobilization or early avoidance of contractures? These are multi-porous shoes. These are used to avoid contractures, especially uh, someone who is not able to perform dorsiflexion. Serial castings are done to avoid plantiflexor contractures. These are goals of early rehabilitation. Coming to active rehabilitation, in a mild to moderate case, there is one approach by a physical therapist that is taken, and that is restorative approach. And the restorative approach is to restore ambulation, improve independency, improve the gait of the patient, restore the dynamic balance of the patient, and improve the cardiovascular strength and endurance through various exercises. So this is the active rehabilitation goal in a mild to moderate case, and the goal is restorative physiotherapy. Improve the muscle strength, body conditioning. What interventions can be done? There is MRP, motor relearning program. It is kind of a program in which we train the patient to relearn activities that he has forgotten after a physical disability. There are three steps in this. First is you can say feedback, other is practice, and one more is the strategy development. In the strategy development, what happens is, for example, there's a mild TBI case, and I say the patient that you need to uh, grab that glass of water from your right hand that is affected, for example. So before initiating this movement, I will tell him to develop thinking in your mind that how would you do this. This is called strategy development. First he will think and then he will perform the activity. Now this is called the strategy development. Then there is a feedback mechanism. External feedback or extrinsic or intrinsic feedback. The external feedback or extrinsic feedback is, for example, I tell the patient that you need to grab this glass of water from your right affected hand. He thinks about the movement and then he brings his left arm first. Then I give him a verbal command that you are not doing it right. There's something wrong. You should use your right hand, as I have said before. So then he corrects himself and uses the right hand. Now he uses my verbal commands to correct himself. That is called extrinsic feedback. Now coming to what is intrinsic feedback. For example, I say the patient to hold the glass of water with the help of right hand. He brings or initiate his left hand's movement, but he correct himself that something is going wrong. He brings his left hand back and uses his right hand and perform the activity. This is called the intrinsic feedback of the patient. Then comes the practice. The more you practice, the more easier the task will be. So these are three things that you need to make learn the TBI patient. Now there are some principles of neuroplasticity. I won't go in deeply into this, but what is neuroplasticity? Once there's a brain damage, so neural pathways of the brain reorganize. There's a neural reorganization in the nervous system. New neural pathways are formed to get back to normal life. That is called neuroplasticity. In TBI patient, in stroke patient, 6 months are very important, and after 6 months it is difficult to increase the neuroplasticity because the neuroplasticity ceases or the progression of the neuroplasticity decreases down. So the first 3 to 6 months are very important. After 1 year, there is a palliative care that a physical therapist or a clinician or a doctor can do. Then there is advanced locomotor training. That is an anti-gravity vest. You put the patient on it. Most of the weight of the patient is held by this anti-gravity vest, and then there are two people or two physical therapists sitting just beside the legs of the patient, and you start making him walk. It is very advanced locomotor training strategy, and it is very useful. I've trained a lot of patients. In the upcoming videos I will show some example of that. I've trained the patient and they are doing really well. The independency level has very much improved. Aerobic trainings are there. Now in the severe case, the approach is compensatory. The approach is compensatory because what happens is once there is a severe TBI, it is very difficult to go back to your ADLs. So the approach is compensatory. If my right hand is not working, I will use my left hand to do all the ADLs. If my core is not working, I will try to lever myself through my hands or my upper trunk to do my ADLs. I will what I will do is I will hire attendant for doing small stuff, small ADLs, activity of daily living in my life. So this is a severe TBI, traumatic brain injury result. In severe, we will use compensatory or palliative care, and in mild to moderate case, we will use uh, restorative approach. So this was a short description, short presentation on TBI. Hope you can stick to this and may have learned not much but an adequate amount of information about TBI. Keep sharing and keep liking my content and subscribe for later videos. Thank you.